Dr. Suresh, can I start? It's 5:31. I think people will join eventually. Shall we start? I will start the introduction and then we can begin.
Yes, ma'am.
Yeah, okay. Good evening, everyone. Welcome to this IN webinar on autoimmune section. We had initial sessions on the basic neuroimmunology, and now we have started the basic disorders, the main disorders. This session is going to focus on the central demyelinating disorders, and the next session will be on peripheral demyelinating disorders. As you can see, we have 4 speakers for this session who will be talking on different aspects of CNS demyelination. Dr. Suresh will cover on multiple sclerosis. Dr. Netra Maisel will cover on NMO spectrum disorders. Dr. Kajuo Fujihara will cover on MOG spectrum disorders, and Dr. Kshitija will cover on GFAP and Clipper syndrome. So after the sessions, we'll be opening up for the Q&A sessions. So I request the participant as the session goes on to post their questions and queries in the chat box. So over to you, Dr. Suresh. So first session will be on Dr. Suresh. He is a consultant neurologist. Initially, he was in Amrita Institute, and now he's in Renai Medicity. Yes, sir. So he focuses mainly on CNS disorders like MS, NMO, MOG spectrum disorders. He has a huge MS clinic, which he started initially in Amrita and then in Renai Medicity. And this caters to many of the patients who are on MS and NMO spectrum disorders. So today we'll have the session from Dr. Suresh on multiple sclerosis, clinical and lab.
Are you able to see my slides?
No, Dr.
No,
Suresh,
sir.
we're not able to see. Maybe you can.
You can reshare, sir.
We have Dr. Rohit Bhatia, who is the chairman of the IN Autoimmune section, who has just joined us. Dr. Rohit, would you want to add a few words? Dr. Suresh, I've just introduced and we were about to start this session.
Are you able to see the slide now?
No,
No,
sir.
Dr.
You have to
Suresh.
go to the Zoom first,
Are you
and
able
then
to,
you can share.
No,
are
Dr.
you able
Suresh.
no?
No.
Go to the Zoom window first, and then share your screen.
Yeah, I think it's come now.
Yes. 1 second, Dr. Suresh. Dr. Rohit has just joined us. Dr. Rohit, you would want to.
Very good evening to all of you, and I apologize for a bit of a delay due to some personal commitments back home. So I welcome you all on behalf of the IN, and without taking much time, Dr. Suresh, please start.
Yeah, thank you. Good evening. I hope you can see my slides
Yes,
and I'm
Dr.
audible
Suresh.
too.
Yes,
Yeah,
yes,
thank
yes.
you. At the outset, let me thank IN for giving us this opportunity and IN subsection of demyelinating illness. With that, we start today's seminar. So I've been given this topic of multiple sclerosis, clinical features, criteria, and treatment approaches. Now, I would say that this is a little challenging to do this in 20 minutes, but I'll try my best, try to. So having seen multiple sclerosis, what have we understood, about this disease? We know that it's a chronic disease characterized by inflammation and demyelination of the central. But what we really do not know is inflammation the pivotal event, or is it a secondary response to something else? MS doesn't have all the characteristics of a typical autoimmune disease, like what if you take a rheumatoid arthritis or an SLE. It doesn't have many of the peripheral manifestations of these diseases, purely a central manifestation. There is a complex interaction between genetic and environmental factors when you look at MS. No undisputed Mendelian form of MS, unlike other chronic neurological diseases like Alzheimer's, Parkinson's, and So as we understand multiple sclerosis, the environmental exposures or non-Mendelian genetics play an important role in this disease. MS develops in a genetically susceptible individuals who experience a sufficient set of environmental factors. No single autoantigen, autoantibody, or infective agent have been unequivocally associated with MS. Historically, MS was predominantly a T lymphocyte mediated disease. Now the role of B cell is indicated. There is an early axonal loss in spite being a predominant demyelinating disease. And what drives this disease in its later stages? Like, is it an aging process or is it something like a meningeal lymphoid aggregates? We need to look at all this as we move along. So coming to risk factors of multiple sclerosis, we know that there are genetic factors like gender, disease modifier, genes, disease susceptibility genes, SNP. So these form the genetic background, and then the environmental. You have smoking, vitamin D, solvents, organic solvents, pollutants, diet, salt, and virus, gut microbiota, exercise, stress. So it's like 85% of the disease is controlled by environmental factors, and 15 to 20% may be contributed by pure genetic factors. So we know if we look at an MS perspective in India, you would see that we really do not have any data coming out from the entire country, but we have looked at MS in parts, in different parts of the country, and then you would see that there is a various prevalence among different parts of the country. Hopefully, with the coming out very soon, we would get a more hardcore data on the prevalence in our own country. But some things which we really come to know from this slide is that it's predominant among the Parsi community. Now, Parsi community forms a small community in the region of Bombay, and Dr. Singhal himself has come out with a prevalence of 1.33 per 1 lakh in the mid 80s. But at the same time, the Parsi community had 26 per 1 lakh. So you see that there are genetic factors, in the South, Dr. Lekha Pandita, she had put a prevalence of about 8.3 per 1 lakh in Mangalore city. So one thing it's sure that in India, the multiple sclerosis disease is on the rise. So what are the clinical features? Usually it's a unilateral visual impairment. About 40% of people start with this unilateral visual impairment. Short segment optic nerve involvement, usually very well responds to steroids. Vision totally comes back mostly. So it's a unilateral visual impairment. Then you have the involvement of the brainstem. So here you can get involvement of cranial nerves. It can be a gait involvement like an ataxia, or there could be an affection of conjugate movements of the eye like an INO. Then the other important part of the central nervous system lesions, where motor sensory impairment of the trunk, limb spasticity, bladder dysfunctions, all involving the white matter tracts, they slowly start manifesting. And then you have the silent cognitive involvement in MS. Other than this, when you ask the patients, they have a whole set of other kind of symptoms, which they say, like they have low mood, they have their cognitive processes have slowed down, they have walking difficulty due to spasticity, they have gait and balance issues, speech becomes a problem after some time, so does swallowing. Bladder and sexual function is a big problem for the patient. Fatigue, 70% of MS patients suffer from this symptom of fatigue. So these are the invisible symptoms which, as clinicians, we are unable to see, but mostly, but this is what the patients actually keep on, experiencing. So when we look at the evolution of the diagnostic criteria of multiple sclerosis, you would see that it has evolved from the earlier Allison-Miller criteria in 1954, which was predominantly dissemination time, to the Schumacher's criteria, where we had both dissemination time and dissemination. The Poser's criteria, where we had clinical dissemination time and space, and also this was backed up by laboratory science, supported science. Then we have the McDonald's criteria, which formed the basis of the current criteria for diagnosis. And this allowed MS in the clinically isolated state to be actually diagnosed. And the 2005 criteria had a greater role for spinal cord lesions and new T2 lesions. And McDonald's 2010 simplified imaging of demonstration of dissemination of CNS in space and time. So, as this criteria evolved, there are other things which also we look, which formed a part of the criteria. One is the neural filament light chain, which is extensively being used now. It's a sign of neuroaxonal damage, and NFL is usually elevated in CSF in all stages of multiple sclerosis, like OCB, and it increases almost 10 times during time of relapse. CSF oligoclonal that we have all been doing in our clinical practice is associated with gray matter atrophy, higher physical disability, and greater cognitive decline over 10 years when they are present, seen in all stages of disease. And level in CSF correlates with the progression of the. Now, this is the McDonald's 2017 criteria we all know about. And, this diagnostic criteria, if you see, it's basically based on if you have two attacks and two different sets of neuroaxis being involved, then the diagnosis of multiple sclerosis become absolutely clear, and then you don't need anything else. But if you have only one single attack and you don't have another attack to show, or if you have only one clinical site and second time the same clinical site gets affected, or you don't have another clinical site, then you can take the help of MRI or a second clinical attack, or CS of OCB as per 2017 McDonald's criteria to show dissemination in time. And taking the help of these, we can actually multiple sclerosis. 2010 McDonald's criteria simplified the MRI for us, and instead of looking at so many areas and so many lesions, it could be just dissemination space can be demonstrated by a greater than one T2 lesion in at least two of the four areas. The two areas being periventricular, juxtacortical, infratemporal, spinal cord, and in the for dissemination time, you could actually get a new T2 or a GAD enhancing lesion on a from a baseline MRI, or a simultaneous presentation of GAD enhancing and non-enhancing lesion as dissemination time, and this could help you to actually make the diagnosis of MS much more stronger. So these are some of the typical sites: the juxtacortical, periventricular, brainstem, spinal cord, and later on optic nerve is also being involved in the diagnosis of MRI diagnosis of MS as another site, which is called. So there are something more going on in the background in multiple sclerosis. This is the smoldering lesions of MRI, which are also called chronic active lesions. They have a rim around lesions, and sometimes these lesions keep on expanding over a period of time. And you can see a patient, with the age of 35, 40, 45, 50, the lesion is slowly becoming more, and this is leading to progression in the disease in spite of relapse. This is another sign which is called the central vein sign. This is seen in the axial SWI images. There's a central hypointense dot in a white matter lesion, and this is the central vein sign. And with the number of central vein sign, we can make the diagnosis of MS more confident in the earlier stages of the disease. Now, this is the short segment of the the differences between optic neuritis, MOGAD, and MS. And you see that MS has usually unilateral optic nerve involvement, which is short segment involvement. So what are the revisions now? The proposed revisions in the 2024 revision of McDonald's criteria. It's including kappa-free light chains, which is a biomarker in the CSF, and which indicates inflammation. The central vein sign is also being incorporated into the 2024 revision of an image marker, which indicates blood vessel in which I have already shown. The paramyogenic rim lesions, which I was saying was also an imaging marker, which indicates iron around the edge of the lesion. Then optic nerve is being seen as the fifth affected area of MS, and then the dissemination in space can be seen by, can be satisfied by lesions in 4 or 5 different topologies, even without dissemination in time. And for radiological isolated syndrome, now, if they meet the criteria of dissemination to space, or either they meet the criteria of dissemination in time, or have CSF biomarkers, or at least 6 and can confidently make the diagnosis of RIS in this according to the new criteria of McDonald's, which is 2024 criteria. And as far as MS is concerned, we all know that we have to treat the disease very aggressively to prevent the end organ damage. And here the end organ is actually the brain. So we want to look at how we can do it. So there are various principles. One is the principle of NIDA, no evidence of disease activity, and it's keeping on increasing from, we all know about NIDA 1, 2, 3, which was no relapse, no disability progression, no MRI activity, but then that has been added on by NIDA 4, 5, 6, where brain atrophy, cognitive involvement, CSF neurofilament are all being increasingly involved. But I think we need to be very practical when we actually bring NIDA into clinical practice. We have to see the patient also and what stage of MS the patient is going through. So there is this entity called benign MS is now actually a myth. There is nothing called benign MS. When these patients have been followed up for a long period of time, it has shown that 45% of them usually have cognitive impairment, 49% have fatigue, and 54% have depression. So it's no longer benign as such. Another principle we can use in the treatment is whether the disease is active or not. So you have clinical isolation syndrome, RRMS, PPMS, and SPMS, and you can decide based on whether there is activity on the clinical side or activity on the MRI. And all diseases where they are clinically active either on MRI or clinically, you should either step up the medications if they are already on medication or start medication if they are not on medications. Now, this is the B cell role, and we know that increasing the role of B cell in the antigen presentation, cytokine production, autoantibody production, and ectopic lymphoid like aggregation. So B cell is now becoming an important player in MS. And this is the chart which I would like to know, see in the stage of MS. If there's a clinically isolated syndrome, then you can use drugs like lateral acetate, interferon, ponesimod. These are the drugs which are available. If you are active disease, then you have a whole plethora of drugs like dimethylphenol, fingolimod, GA, lateral acetate, interferon, ocrelizumab, or in fact all the monoclonal antibodies. And for highly active diseases, you have alemtuzumab, cladribine, fingolimod, natalizumab, ocrelizumab, and ofatumumab. Now, in the SPMS stage, we only treat the active SPMS. So we have siponimod, ponesimod, and ocrelizumab and ofatumumab can be used in the active MS. And ocrelizumab is a drug which can be used basically in the early PPMS stage. It's the only drug which has been approved for early PPMS treatment. So the strategies can be either wait and see in a very early multiple sclerosis, or you can do a maintenance and then escalation of the medication, or you can go for the third therapy, which is the induction therapy. So whatever you do, it should be a balance between the safety and the efficacy of the drug as far as the patient is concerned. So you have the conventional step care approach where you start with low efficacy drugs and go to higher efficacy drugs, or you have a rapid escalation with the disease is more aggressive. You quickly jump from the lower drugs to the higher drugs quite fast. And then you have the top down, flipping the pyramid down. That means you are going with high active drugs quite early in the disease, especially when the disease is very, very active. So what are the factors in decision making? The risk benefit profile of the DMT should be taken into account. The preferred route and frequency of DMTs as far as the patient is concerned should be also taken into account. Disease burden, prognostic factors should be seen. Comorbidities of the patient should also be taken into account when you are selecting a DMT. Planning of pregnancy is very important. The willingness of the patient to take a risk is also important. And then, of course, in India and many countries, cost becomes a big factor. So this is roughly about the Minactrim's algorithm, where what I've told you earlier, only we divide the disease into moderate active disease, highly active disease, and rapidly evolving disease. For moderately active disease, we start with the platform therapies. If there are side effects, we interchange between the platform therapies. And if that doesn't work, we can go to higher drugs like natalizumab, oral cladribine, etc. And finally, drugs like cyclophosphamide, mitoxantrone, and stem cell therapies are kept when there is a suboptimal response to all the other drugs which have been given before them. So this is the algorithm you can just keep in your mind as you're treating multiple sclerosis. It covers all the stages of the disease and all the drugs which are possibly involved here. So this is the Minactrim's algorithm for the treatment of RRMS. The pediatric onset MS is slightly different from the adult onset MS. The children usually have more like an encephalopathic presentation, especially children who are less than 12 years present more like an ADM presentation. Many of them have MOG antibodies which are positive, while the older children behave more like the typical multiple sclerosis of the adults, and they are very amenable to the disease modifying therapies which are currently available. Though all drugs have not been actually given an approval by the FDA for use in pediatric MS, but there are many drugs like interferon beta, fingolimod. So these drugs have been allowed and to be used in patients with MS. So this is about the pregnancy and planning of pregnancy is very important because many of these disease-modifying therapies cannot be used during pregnancy. Interferon beta-galactosamine acetate are safe. DMF actually cannot be used during pregnancy. Natalizumab can be used in the first 2 trimesters, but not later. Alemtuzumab, ocrelizumab cannot be used during pregnancy. And teriflunomide is a total no-no with the red flag sign. So stopping DMT is another big question, and whether we are going to stop and when are we going to stop. There's no real answer yet. But in older patients with less inflammation, going to SPMS stage, benign MS, so-called benign. I said there are no benign MS, but still, if it's not active, then we can think after 5 years of stopping it. So coming to the conclusion, the treatment of MS should be done as early as possible. In mild moderate disease activity, first-line therapy are the drugs of choice. High active disease needs early escalation from first-line to second-line therapies. Rapidly progressive MS ideally needs a top-down strategy. There is no universal definition for aggressive MS, nor there is an uniform pattern of escalation strategy. Decision is always based on efficacy versus safety and prognostic factors. Pediatric onset MS vary slightly in their presentation and progression. Most drugs used in adults have not been studied in pediatric age group. Pregnancy has its own challenges and therapy and has to be carefully planned. Soon the era of personalized medicine will come into MS therapy. So over the last 25 years, the treatment and management of multiple sclerosis has been totally transformed. Who would have thought that we would be targeting NIDA and potentially end organ damage as a realistic treatment target for people with MS and defining what a potential cure looks like. So thank you for the patience.
Thank you, Dr. Suresh. Very nicely you covered the aspects of multiple sclerosis straight from when it started and the different aspects of the criteria, how it is evolved, especially the McDonald's criteria, which has recently been changed to the 24 criteria. You brought about the change in the DIS and DIT. Thank you. We'll take up the questions at the end of the session, Dr. Suresh.
Sure, we will do that.
So now we will have the talk on NMO spectrum disorders. My slides are visible?
Not yet visible.
Now is it visible?
No, ma'am. It just
No.
coming.
No?
Yeah. You have to just wait, ma'am. Just now it's showing.
Okay. Okay. Is it seen now?
Yeah. Yeah, it's showing.
Okay. A very good evening, everyone. So after this talk on multiple sclerosis, I would like to talk on NMO spectrum disorders. At the outset, I would like to tell, as the convener of autoimmune section and the chairman, Dr. Rohit Bhatia, we had decided that both of us will not give these talks on in any of the IN webinars, but there was a last minute change from another person, so I had to take up this talk. So NMO spectrum disorders, when we talk, if we have to know how it has revolutionized, especially if you see, this is the gamut of the different type of spectrum of demyelinating disorder. So if you actually take the clinical features of most of these, you either have the optic neuritis, the myelitis, or the brainstem syndrome, which is very common in most of this. So how do we differentiate? And even before the lab tests are available, how do we make out that it is NMO spectrum disorders, and how do we manage these patients? That is going to be the crux of my talk in the next few minutes. So this, I think most of you are aware as to how it was discovered. So basically, it was discovered by David Galt, especially when they did the thesis, and they found that there were patients where there was involvement of both the optic nerve and the spinal cord. Eventually, they realized that it was not just one-time event; there could be relapsing cases. And Wingerchuk gave the first criteria, and after that, Vanda Lennon discovered the aquaporin antibodies, and eventually this got revised. But now, eventually in 2015, the IPND criteria came up, especially because knowing that no more we have patients where aquaporin is positive. Sometimes we may have patients of where we think it is NMO spectrum, but aquaporin is negative, and few of them turn out to be MOG spectrum disorder. So one thing what I would want to tell is whenever we talk about a primary demyelinating disorders, one of the things after multiple sclerosis is considered is the NMO spectrum. But no more we think about that. So this is very beautifully brought out in this cartoon. So if you see this, the blue ones are the myelin sheath. So these are basically affected. That is, demyelination happens of these Schwann cells in multiple sclerosis. And then these myelin is produced by oligodendrocytes, and that is affected in MOG-related disorders. But if you take all these nerve cells, you have these supporting astrocytes. So astrocytes are the food processors. You have the water channels where you have the where you have aquaporin antibodies which are released, and they produce the astrocytopathy resulting in NMO spectrum disorder. So that is the reason we need to understand this, because most of the time we think that all three are same. All three are not same. As we know now, all three are different. The pathophysiology is different. How they respond to treatment, how do we approach, and the treatment is completely different in all these three disorders. So if you take the epidemiology, it varies in different countries. You can see here in India, the study was from Dr. Lekha Pandit, which showed about 2.6 in 1 lakh individual. As expected in any other autoimmune disorders, this also has a female predominance. So as I said previously, either they can present as optic neuritis or myelopathy. So, but when they present with optic neuritis, how do we make out in the clinical features? One of the things is whether it is a unilateral or bilateral. Most of the time, it is usually bilateral. More than being bilateral or unilateral, it is about the severity of the visual dysfunction. When I say severity, it's about how much is the visual chart is reflecting. That is a Snellen's chart. When you check the visual acuity, you find that most of these patients progress to develop visual dysfunction in the first few days, either within 2 to 3 days or maximum 5 to 7 days, that they progress to having complete blindness or just having perception of light or 6/60. So the severity of the visual dysfunction is most severe in these cases. Apart from this, I think this is a very well-known figure to many of them, but at least it gives you an idea, especially when you do the MRI. Previously, optic neuritis was just a clinical diagnosis, but now it's no more a clinical diagnosis, but we also use many investigations, especially the MRI. So when you take the MRI based on whether it is short segment or long segment, especially when it is long segment, if it is going very posterior, that is towards the optic chiasma, it goes in favor of NMO spectrum disorders. And always remember, they may have poor response only to steroids. Unlike MOG-associated optic neuritis, which just melts away with steroid, whereas NMO will not be sufficient. Steroids will not be sufficient in NMO. They will require plasmapheresis apart from steroids in the acute period. So these are the few things which we need to remember in a case of optic neuritis because of NMO. That is, the severity is high. It's a long segment optic neuritis, mainly in the towards the optic chiasma, and response is poor to steroids and may require plasmapheresis. Same thing with the myelopathy, it's usually a complete spinal cord involvement. When I mean complete spinal cord, if you remember most of your patients of your multiple sclerosis, you will remember that they may just come with little bit of posterior column sensory loss in either the hand or the leg, or they may present as a CTS. You may think it as CTS, but when you examine, you find there are pyramidal signs. And when you look, there may be a short segment. Whereas in these NMO spectrum disorders, it is a complete spinal cord involvement resulting in a motor sensory bowel bladder involvement. And the paroxysmal episodes are more common in NMO spectrum disorders. And we know that usually it is a LETM, that is longitudinally extensive, more than 3 vertebral segments. So this is a very important figure, but it reflects on the spectrum which can be there in NMO spectrum disorder. So it could be optic neuritis, cerebral involvement. Cerebral involvement could be in the form of behavior, cognition, or mainly psychosis or associated with NMDA encephalitis. And then you have the diencephalic syndrome, where you have either the patients presenting with narcolepsy or increased eating and weight gain, as well as thirst. Then you have the brainstem syndrome affecting either the ataxia with either of the multiple cranial nerves, and then the area postrema syndrome, where you have the hiccups, vomiting, and ataxia, which could be there, and then the myelopathy. So these 6 form the core clinical features of NMO spectrum disorders, and mainly these 3 are considered as the most important core clinical features of NMO. So this was one of the study which we did in our patients. What we found that is that apart from these 6 clinical features, most of these patients usually present with pruritus. That is, usually before the myelopathy starts, we know that most of the time you can have element clinical features at the level of the lesion, but we also found that they can have pruritus at a dermatome level at that point of time where they have the severe involvement. If you remember your MRI, most of your NMO patients will have those bright spotty sign that is suggestive of axonal involvement and axonal damage. So you find pruritus in a specific dermatome. So you can see this picture of a lady who had intensive pruritus, and you can see the scars because of the pruritus. So this we found in many patients with NMO, and they are definitely different from those patients without pruritus. And you also can have element clinical features, especially you may not find this in other demyelination like multiple sclerosis or MOG, but you can find these element signs, especially in NMO spectrum disorder. So you can see here in our muscle wasting, this was one boy who had a long segment myelopathy from childhood, and then eventually he developed kyphoscoliosis, and this is a and then developed a terminal palsy. So element signs can be present in case of NMO spectrum. Apart from this, you also can have association with either the peripheral, like or central, like NMDA encephalitis, and especially when they have a brainstem or a postuma, they also can develop hydrocephalus. So diagnosed with the chiplet was just the clinical, which was having a lower sensitivity and specificity. And eventually it was revised in 2006, and now we have the IPA. Mainly, though this criteria looks big, what you need to remember is one thing is among the core features, you should have at least one core clinical features, then it fits into your criteria of NMO spectrum disorders. Of course, you need to exclude other alternative diagnoses like MS and MOG. So you can see the Wingert-Schuck was only based on clinical and MRI. Then it was based on the presence of aquaporin, but 2015 criteria involves patients where you can have even aquaporin negative, but behaves like NMO spectrum disorder. CSF is very important, at least in a place like India, where you can have gliocytosis. Please remember that most of the time you have to take the clinical picture into consideration. because CSF pleocytosis is commonly seen in hemospectrum disorders, and it can be mistaken for an infection like tuberculosis in India and mistakenly treated with anti-tubercular agents. But you have to take the clinical feature as well as the MRI before you make out whether it is demyelination or infected. Apart from this, you have aquaporin 4 being tested in multiple labs. Remember, it's always a cell-based assay which has to be tested. But in the cell-based assay also, you have something called as a live cell-based assay and fixed cell-based assay. What we use at NIMHANS is a fixed cell-based assay, but what is recommended is a live cell-based assay, and it has to be in serum, not in CSF. Of course, there can be few patients with CSF positivity, but serum is more important in the testing of aquaporin. Apart from this, you also can have multiple other ANA positivity which can be there, which tells that there could be having a associated Sjogren's or a SLE. So MRI, as I said, you can see here, this is showing optic neuritis, optic atrophy, the second picture, long segment myelitis, bright spotty sign. Apart from that, you can also have the area posthuma syndrome across the ventricles and even across the ependymal region. So treatment is in the acute period, it is corticosteroids and plasmapheresis. Remember, it is not just corticosteroids, but plasmapheresis. And in the maintenance, it is about having other therapies. So this was, okay, so this was one of the, what we came up after we analyzed around 101 patients of aquaporin for antibody disorders and brought about this algorithm. So in the acute period, you treat them with steroids, plasmapheresis, and always remember, don't think that patient has responded. We will not give any treatment in the maintenance period. Aquaporin 4, when it comes back again, it does not cause a progressive disorder like MS, but the disability accumulates with each of the attacks. So your aim is to prevent a next attack, and that's the reason you need to give them maintenance therapy. So we need to understand the pathophysiology before we understand the why we need different type of treatment. Of course, now we have a lot of monoclonals which have come into the pipeline, and it is being used because it is not yet being started in India. I'm not going into those which are being used in India. I'm going to stress most of on those features. So you know that you have a T cell which is then activated by B cells, and then you have release of aquaporin which goes into the bloodstream and eventually causes a astrocytic damage. So this is what happens, and eventually you have the coagulate release and then down regulation of EAA2, which results in astrocytic activation. So this pathophysiology, if we remember, we will remember why each of the drug is being acting on different parts of this pathway. So for example, we use immunosuppression, which acts basically in this place where it prevents the B cell being activated into plasma cells and release of aquaporin. And the same thing with monoclonals. The plasma exchange is acting at this bloodstream level where it washes out the aquaporin 4 antibodies. And then you have the newer antibodies, which are complement inhibitors, as well as which are acting on either IL-6 or other aquaporin 4 antigen. So one thing which I want to stress upon is about the plasmapheresis, why it is important, because many of them feel that because steroids is enough, they go away straight away with rituximab or sometimes even tocilizumab. But plasma exchange is very important. So you can see here, this study showed, it's a very old study, but it showed how the EDSS improved with when plasma exchange was being given. And especially you can see here, when this study showed that whenever there was a delay in giving the plasmapheresis. So you can see here, when there was a delay by 1 week, there was a 30% reduction. Whereas when there is a 1 month delay, there was 77% reduction. That means 33% only improved when there was a 1 month delay in giving plasmapheresis. So your disability is going to accumulate more when you do not give the plasmapheresis in the acute period. And this is one of the very good study which has shown. So you can see here, the plasmapheresis when it started in the acute period, within hours. You can see here, though the damage is so much in the acute period in the first MRI, When the plasmapheresis started early, you can see that the spine is normalized almost completely. But with time, when the plasmapheresis is delayed, you see that there is an atrophy and cavitation which presents, and this leads to disability. So time is God and eyes, and that's the reason plasmapheresis is important in a person with multiple sclerosis, in a person with aquaporin 4 NMO spectrum disorder. So maintenance therapy, I'm not going into the details. Mainly what we remember is that there are many studies which have shown, of course, this study showed the superiority of rituximab over azathioprine, and all three are useful, but of course the efficacy is slightly more with monoclonals followed by other immunosuppression. And now we have many other newer drugs which have come up, especially in nebulizumab, eculizumab, satralizumab, which have come up. And you can see here, these are definitely more effective. You can see here, eculizumab is almost 94 to 96% efficacy, and all of them have been FDA approved. So coming to our work at NIMHANS, so this is a study which we did on 101 patients of aquaporin positive NMO, and we found almost similar, but what we found mainly is the efficacy of the azathioprine and mycophenolate. See, what I want to tell is in the Indian context, because we have so many monoclonals coming up. So what we also found was among the three, azathioprine mycophenolate also fared good efficacy, but the side effect profile and mortality was slightly more with azathioprine. Apart from this, again, this was another study which showed the efficacy of rituximab, especially in aquaporin 4. And these are few other case reports, but it shows about how sometimes aquaporin can be mistaken to be a tumor and they can be operated upon, especially because the way so badly they present. And NMO can have a HLA association and be present with other syndromes like Sjogren's. And even we have double positivity with aquaporin and MOG. So finally, what I would want to tell is we have learned a lot from other demyelinating disorders, but NMO stands apart from all of this. And we know that clinical features can differentiate between other demyelinating disorders, and it's an astrocytopathy. It's not just a pure demyelination, it's an astrocytopathy. And always test the serum. It's not a CSF, it's a serum. Live cell-based assay has to be done, followed by fixed cell-based assay. And remember, not all LETM is aquaporin. See, for example, this was a spinal cord infarct, which was mistaken as a aquaporin 4 related disorder, and this was a dural AV fistula. And this was another patient who had sarcoidosis and was referred to as NMO spectrum disorder. So not all LETMs are NMO spectrum disorders. And in the acute period, please give plasmapheresis. You saw how nicely the spine, it improves with plasmapheresis. And of course, maintenance therapy is a must. Thank you. Thank you. So now we will have the talk from Dr. Fujihara. Dr. Fujihara, I would like to introduce.
Thank you very much. And let me share my slides.
Yeah, Dr. Fujihara is a professor, Department of MS at Fukushima Medical University, Tohoku Research Institute of Neurosciences, Japan. He has a lot of work on MS, NMO, MOG-related disorders. Apart from that, he's also a member of the IPNT criteria, McDonald criteria, also MSIF, ECF. He's also a member of the patrons and also honorary member of the Association of Sri Lankan Neurologists, Indian Academy of Neurology, Hong Kong Society. So his CV runs into a lot of pages. Wouldn't want to take much time in his introduction. So over to you, Dr. Fujihara, for your talk on MOG-associated disorders. Thank you.
Dr. Netravathy, well, thank you very much for the kind introduction. First, I would like to thank Dr. Netravathy Dr. Bhatia and other organizers for this opportunity. I'm very much happy to be here today. In the next 20 minutes, I would like to share with you what we know about MOG antibody-associated disease, or MOGAD, which is a relatively recently recognized clinical entity in neurology. For some reason, I cannot move. Okay.
Sir, you could just double click on the screen.
Oh,
Double
okay.
click on the
Okay. So these are my disclosures. So let me explain myelin oligodendrocyte glycoprotein, or MOG, first. So it's a membrane protein, and it's localized at the extracellular surface of oligodendrocyte and outermost lamellae of myelin sheath. And it's a relatively minor protein in the myelin. And function is not fully understood, but it seems to contribute as an adhesion receptor and compaction and maintenance of myelin. There are a number of different MOG-IgG detection assays, but the previous studies done with the peptide ELISA and Western blotting showed low specificity, and it showed confusing results. And immunohistochemistry was low sensitive. So we should use cell-based assay and full-length human MOG. And as for secondary antibody, FC or IgG1 specific ones should be used to detect conformation-sensitive MOG-IgG. As you all know, in ELISA, the MOG peptides are linearized. In Western blot, protein is denatured. So it does not contain the conformation, three-dimensional structure of MOG-IgG. But we should always be careful about false negative and false positives. Last year, the first ever international diagnostic criteria of MOGAD was published. This is the diagnostic process. So first, your patient present with one of the 6 core clinical demyelinating events, where optic neuritis, myelitis, ADM, and so on. I will explain them later. And of course, you should detect MOG-IgG. Usually, you should test serum by cell-based assay. And if the antibody titers are high or clear positive, no additional supporting features are required. But if the titers are low or low positive, or although it's positive, but titers are not given, or serum negative but CSF positive, you should prove that the patient is seronegative for AQP4 IgG, and your patient should fulfill at least one supporting clinical and MRI features, which are shown here. So those for optic neuritis, myelitis, and brain brainstem syndromes. As you see here, bilateral simultaneous clinical involvement and optic disc edema are clinical features, but the remaining supporting features are all MRI features. I will explain them later in my talk. And finally, you should exclude alternative diagnosis, including multiple sclerosis. About a year ago, the international panel investigators collected more than 600 cases to evaluate the performance of the diagnostic criteria. And as a result, 90% of the cases met the criteria. About 2/3 of them had clear positive MOG-IgG, and the remaining 1/3 were low positive or non-titled MOG-IgG, but they fulfilled supporting criteria. In the remaining 3% of the cases, which were either optic neuritis or myelitis, the patients did not fulfill any of the supporting features. So these 3% were not diagnosed with MOGAD at this point. But overall, international MOGAD diagnostic criteria is very useful in making the diagnosis of MOGAD. So let me show you the positive results and negative results by cell-based assay in serum and CSF. This patient was positive in both serum and CSF, but this one, seronegative, but CSF positive. While in this patient, serum was positive, but CSF was negative. These are all MOGAD cases, but there are false positive cases. Both of them were clinically diagnosed with MS, seronegative, but both cases were faintly CSF positive, but these are probably false negative results. But there are some issues of MOGAD detection in the diagnosis of MOGAD. And as you see here, there are some cases with CSF-restricted MOG-IgG positivity. So they were seronegative, but CSF positive. But as you see here, the frequency of those CSF-restricted MOG-IgG positivity ranged from 0% to over 23%. Probably those wide variations are caused by different detection methods, different cutoffs, different cohorts, and the different timings of the CSF collection. Moreover, a recent report showed that some patients may be MOG-IgG negative, but MOG-IgA positive. And more recent study showed that a small number of cases may have exclusive MOG-IgG 3 seropositivity. So the story is becoming more and more complicated. Now let me talk about the epidemiology of MOGAD. So there's no marked sex or racial predominance in MOGAD, and the average onset age is about 30. Compared to MS, prevalence and annual incidence were lower, but roughly 1/3 of the cases may develop the disease as a post-infectious disease, and a small number of cases may be post-vaccinal. In Japanese nationwide survey, influenza and Japanese encephalitis vaccines were the commonest ones. The coexisting autoimmune disorders are relatively uncommon in comparison with AQP4 positive MOGAD and NMOSD, but NMDA receptor antibody may occasionally be detected in some patients with MOGAD. Relapses may be seen in roughly half of the patients. Although the acute phase, the disability may be relatively severe, but usually recovery is good. And unlike MS, no progression is seen. And unlike MS, no latitude gradient, racial preponderance, or HLA associations are seen in MOGAD. So now let me talk about the clinical phenotypes of MOGAD. And these 6 clinical phenotypes highlighted by red are the 6 core clinical demyelinating events in the diagnostic criteria. So the common ones include optic neuritis, ADEM, and transverse myelitis, and less common presentations include cerebral cortical encephalitis, brainstem cerebellar demyelination, and cerebral monofocal and polyfocal CNS deficits. But 3 other less common presentations were also shown here, like tumefactive brain lesions, cranial neuropathy, and the leukodystrophy-like disease in children. Overall, optic neuritis is the commonest phenotype, but in children, ADEM is the commonest, followed by optic neuritis. And in adults, optic neuritis is by far the commonest, followed by transverse myelitis. So let me start with MOG-positive optic neuritis. So the patients develop central acuity loss, retroorbital pain, color vision loss, and if it's unilateral optic neuritis, you may observe RAPD. And essentially, the MOG-positive optic neuritis involve anterior visual pathway. So you may see a optic disc edema like this one. Bilateral optic neuritis is relatively common and may be seen in up to 60% of the cases, and relapses may be often common and often unilateral. And relapsing optic neuritis may be called a CREAM, or chronic relapsing inflammatory optic neuropathy. But the recovery is often rapid and good. And as for MRI findings, as you see here, optic nerve lesions are long, edematous, and bilateral. And also, perineural enhancement is relatively a unique feature of MOGAD optic neuritis. Next, MOG-positive ADEM. So it's a polyfocal CNS involvement plus encephalopathy. And as I said, it's the commonest presentation in children less than 10 years old. And it may associate with optic neuritis and or transverse myelitis. And infectious episodes may be seen in more than half of the cases. But like optic neuritis, usually the complete or near complete clinical MRI reservations are seen, especially in children. But occasionally, it may cause relapse, and it may called as a multiphasic DEM or MDEM or optic neuritis. On the right-hand side, you see the typical MRI features of MOGAD ADEM. So here you see a bilateral thalamic lesions and large ill-defined T2 white matter lesions, as they are essentially bilateral, ill-defined, and large, and often with deep gray matter involvement. On rare occasions, MOGAD may cause a life-threatening disease. And as you see here, in boys, there's a severe brain edema and almost causing brain herniation. And they were unresponsive to IV methylprednisolone, IVIG, and PLEX. However, their CSF IR6 level was quite high, and they were successfully treated with anti-IR6 receptor monoclonals in children. Next, transverse myelitis. And this myelitis may be relatively severe at nadir. EDSS is more than 4 in more than half of the cases, but like other phenotypes, the good motor recovery is often seen. However, in some patients, permanent sphincter and sexual dysfunctions may be seen. Unlike optic neuritis, recurrent transverse myelitis is rare. And as for MRI findings, longitudinal extensive spinal cord lesion is seen more than 60% of the cases, and usually it's centrally located. And as you see here, H sign is relatively unique feature of MOG transverse myelitis. And gather enhancement may be seen in half of the cases. But you should not forget that up to 10% of the spinal cord MRI may be normal at onset. So then a few days later, you should check the spinal cord MRI again. The clinically silent spinal cord lesions may occasionally be seen in patients with brain and optic nerve symptoms. And the cornus lesions are relatively common in comparison with MS and AQP4 positive NMSD. But in the long follow-up, most lesions resolve or reduce in size. Some patients may develop both optic neuritis and longitudinal extensive transverse myelitis. So those patients are called MOG-positive NMO. 7 years ago, we reported the cerebral cortical encephalitis with seizures. And as you see here, unilateral cerebral cortex is hyperintense on FLAIR image, and on SPECT, hyperperfusion is seen corresponding to the hyperintensity. And pleocytosis is seen, and often seizure develops. And anti-epilepsy drug alone is not effective, but the IV methylprednisolone is effective. And after a few months, cortical lesion disappeared. But there's another type of cerebral cortical lesions. We experienced a 46-year-old male, and first he developed seizure, but he became progressively paraplegic. But spinal cord MRI was completely normal. But then brain MRI was checked, and as you see here on the coronary view, you can see the U-shaped lesions, probably at both tips of this U-shaped lesion, leg motor areas are involved, and that's why the patient became progressively paraplegic. I do not go into the detail of the brainstem lesions in MOGAD, but cerebellar peduncular lesions are relatively common in MOGAD, while in NMOSD, dorsal medullary lesions are relatively common. Occasionally, you may encounter the patients with large cerebral lesions or diffuse lesions, and those patients may be brain biopsied to rule out the possibility of brain tumors. Cerebral monofocal and polyfocal CNS deficits may involve various parts of the brain. And in rare occasions, you may see patients with cranial neuropathy. Trigeminal nerve is the most commonly involved, but as you see here, other cranial nerves may also be involved. In younger children, which is younger than 7 years old, you may see leukodystrophy like diffuse lesion. And the patients developed subacute encephalopathy, behavioral changes, ataxia, and seizures. As for the relapse of the MOGAD, we recently reported the 10-year follow-up, and in this study, roughly half of the patients experienced a relapse. And as you see here, in the first 5 years, the relapse was more frequent than in the second 5 years. But some patients develop the first relapse after 10 years of onset. And some patients may experience multiple relapses, as you see here. You may have an impression that MOGAD attacks are relatively mild. But as you see here, this is an Oxford study. Recovery from MOGAD attacks are not always good. Maybe 20 or more than 30% of the patients may carry poor recovery. So you should be careful. And azathioprine, mycophenolate, mofetil, rituximab can reduce the risk of relapse, as you see here, in comparison with no treatment. And here you can see the hazard ratio. And interestingly, like NMOSD, MSDMT is not effective in MOGAD. This is a meta-analysis of the treatment effect of azathioprine, mycophenolate, rituximab, IVIG, and tocilizumab. IVIG and tocilizumab's efficacy is relatively good, while rituximab's efficacy is not very impressive. And this is a meta-analysis of the treatment effect of rituximab in MOGAD. Overall, about 55% of the cases were relapse-free. So nearly half of them experienced relapse. But the IVIG seems to be very promising. And in this international study, 34% of the cases had relapse. Namely, 2/3 of them did not experience any relapse while receiving IVIG. But high dose, which is 1 gram per kilogram of IVIG every 4 weeks or more, was more effective than lower doses. Well, as for oral corticosteroid treatment, Australian group recently reported that equal to or more than 12.5 milligram per day for at least 3 months resulted in the nearly 90% reduction in relapse risk. And more recently, the early treatment is better than late treatment. This is a Korean study that, and early treatment of the first MOGAD attacks. So early is less than 5 days, and late is more than 14 days. Late treatment was, in comparison with early treatment, caused a much higher rate of relapse. And of course, non-steroid immunosuppressive maintenance treatment was effective to reduce the risk of relapse. To summarize my talk, the international diagnostic criteria of MOGAD published last year are useful and utilized in clinical practice and research. And understanding the clinical features is essentially important for the acute, early, and accurate diagnosis. Although I was not able to mention, but some other clinical phenotypes like aseptic meningitis, prolonged fevers, increased intracranial hypertension have been reported. So the clinical spectrum of MOGAD may be expanded in the near future. To avoid false positive, especially in MS, a few percent of the patients of MS may show low positives. So essentially, MOG-IgG test should be done in cases with typical features of MOGAD. And finally, therapeutic data to prevent relapse of MOGAD are being accumulated. And I did not go into the detail of the currently ongoing randomized control trial, but 2 randomized control trials, namely the monoclonal antibodies to neonatal FC receptor and IL-6 receptor, are ongoing. Probably in several years, these drugs may be approved as an first ever approved treatment to prevent relapse of MOGAD. With that, thank you very much for your attention.
Thank you, Dr. Fujihara. Very apt to have this talk from you, who is part of the MOGAD criteria. So, few things, what you really brought about was about the testing of MOG, which should be done, and 9 features, which are their clinical features, different types apart from the 6 core clinical features. And the IVIG, many of them, most of the time, they think it is MOG is something like a seronegative NMO spectrum, and they just try to treat it as aquaporin, but it is not so. There are other medications other than rituximab, especially IVIG and tocilizumab, which is coming up. And of course, if unlike other demyelination, here we should have a more lower, more period. I think at least 3 months there should be steroid. After that, it should be withdrawn. I think that you brought about very well. Thanks a lot, Dr. Fujihara. Thanks
Thank
a
you.
lot. Thank you. Now we go over to the next talk by Dr. Kshitija Jain. She has done her postdoctoral fellow in demyelination at Enhance, and now she is a fellow. She's a McDonald fellow at Milan, Italy. Kshitija, over to you.
Thank you so much, ma'am, for the kind introduction. And I would like to thank at the outset the organizers of the webinar, the chairpersons, and the Indian Academy of Neurology Autoimmune Disorder Subsection for this opportunity. And thank you to all my previous speakers who delivered great talks. But as I realized that coming from MS to NMOSD to MOGAD and to now Clippers and GFAP, which are essentially, I think, the least known about. So I'll try my best in the next 20 minutes to cover most of what we know about the 2 diseases. Is my screen visible?
It's not a slideshow, Kshitija.
Yes, I know that, ma'am. Sorry, I just give me a second. Okay, is that okay now?
Yes, yes, yes.
Okay. So, I think my introduction's already been given, so I'll skip, and I don't have any disclosures. I'm working as a fellow, but this presentation has been done in an individual capacity. Okay, so to start off, I would like to start with a case. And so this is a 31-year-old female who presented with numbness of bilateral forehead along with paresthesias of the face and back. And this was on a background of headache, nausea, and vomiting. The MRI showed punctate enhancement in the pontine and peripontine region. And subsequently, in the CSF, there were 2 lymphocytes that were found. Protein was 40 milligram per deciliter. No oligoclonal bands were seen. And so this patient, based on the clinical and MRI features, was treated as a case of clippers and was treated with steroids, IV methylprednisolone for 5 days, followed by 500 mg for 3 days, and subsequently with oral steroids. Patient had a rapid resolution of both clinical and radiological features, and the 3-month MRI also showed resolution of the enhancement. This is a case that I have taken from a journal, and I have mentioned it below. So coming to the disorder, it's called Clippers, which is an acronym for chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. Sorry. Yeah. It's visible, right? My screen?
Yes, yes, yes.
Yeah. So this was a disorder that was first described in 2010 by Dr. Sean Pittock et al. At the Mayo Clinic. And it is a CNS inflammatory disorder, which, as is mentioned in the name, has classical radiological and pathological findings, which kind of are the crux of the disorder and based on which most of the diagnosis is also made. The disorder is centered in the pontocerebellar region, and so most of the symptoms also are referable to this area. It's a T-cell mediated disorder with a very poorly known pathogenesis as well as etiology. There have been multiple hypotheses that have been put forth that it's possible that there are particular antigens in the perivascular area which are more concentrated in the brainstem, and because of which probably this disorder presents in this way. It mainly affects middle-aged males with a male is to female ratio of 3:1, and with a mean age of around 46 years, but so generally in the 5th decade of life. So when do we really suspect Clippers? It's a patient that in the right demographic profile presents with gait ataxia and diplopia, but also other brainstem symptoms like dysarthria, which is mainly an ataxic spastic type of dysarthria, or abnormal facial sensations. These are common symptoms that are seen with Clippers, but there are other features that can be seen which include vertigo, dysphagia, long tract signs, cognitive dysfunction. And though I should mention that symptoms like headache, nausea, fatigue, these are relatively rare or uncommon in Clippers. So it could be an atypical symptom if a patient presents with this. There were also seen that patients with Clippers versus non-Clippers, there are really no significant differences between the clinical features, and so this is not a good marker to decide whether a patient has Clippers or non-Clippers. So it's just giving you that these are the common symptoms, and so you should then go on to investigate the patient. The ones that are red flags, you should also always be mindful of these, and these are generally absent in Clippers, is the altered consciousness, meningism, cortical signs, hypothalamic dysfunction, polyneuropathy, and systemic symptoms, you like the systemic B symptoms that you see with lymphoma, or also the systemic symptoms that you see with connective tissue disorders and other autoimmune disorders. So coming to what we classically know and see, and so this is the first time that where it was described in the 8 cases, the classical MRI picture of punctate or curvilinear enhancement seen in the brainstem, which was predominantly in the pons, but also adjacent to it in the middle cerebellar peduncle or the cerebellum. So let's go to what really are the features of these. And so the classical MRI features is something that we should keep in mind. And has been called, this classical feature that you see here has been called the peppering of the pons, or a salt and pepper appearance. And like I already mentioned, they are punctate, they are curvilinear, predominantly in the pons, but also adjacent to it. So pontocerebellar. And they are small, they are less than 3 millimeter in size. And one thing that should be remembered over here is that these lesions are more prominent on contrast enhancing scans than on even T2 weighted imaging. And so this should be kept in mind. They are bilateral, they are homogeneous. And though the size mentioned is 3 mm, there have been reports where even nodular lesions, which are between 3 to 9 mm, can be seen, but it should be considered an atypical sign, if not an outright red flag. So the most classical is less than 3 millimeter. The characteristic finding of this disease is exquisite responsiveness to corticosteroid, which is both clinical as well as radiological. So this is an important thing to be borne in mind. The lesions, as can be seen in pons, but they also can have an extension in like caudally to the medulla and spinal cord, as well as rostrally upwards to the thalamus, basal ganglia, and the cerebral white matter. So the last point which I would like to mention, and I think it's not highlighted enough in clippers, is also that atrophy can be seen with these patients, which can be seen even early and even with prompt treatment. So this should be also remembered. And they can be seen in the pontocerebellar region as well as in the cerebral cortex. So it is just something that is not seen in all patients, but it can be seen. These are images of the where the lesions can be seen in the spine, which have a similar morphology, and so they are small, they are punctate, and they are more prominent on the GAD enhancing on post GAD enhancement. So also the same with the spine, and then seeing rostrally going up to the basal ganglia. So I would like to present a case for which I would like to thank Dr. Netravati for kindly sharing the case details with me. And so this was a patient, which is a 57-year-old male who presented with cognitive and behavioral symptoms for like 6 months duration, which were mainly frontal dysexecutive, disinhibition, and memory impairment. The MRI of the patient showed bilateral hyperintensity on T2 flare images, which were asymmetric right more than left hemisphere, predominantly frontal, but also seen in the anterior temporal regions, and not seen here, but were also seen in the external capsule as well. It was not restricting on diffusion, and you can see here that on the post GAD scans that there's a very classical peppering enhancement that can be seen in the corresponding area. Because of the atypical presentation, the patient had also undergone a biopsy, and this biopsy taken from the frontal cortex can very beautifully, you can see that there is a perivascular dense infiltrate of lymphocytes, and on the immunohistochemistry it was shown that there were more CD4 positive T cells and also some microglia, and you can also see that you don't classically see the features of vasculitis in these slides. So the patient was then treated with the steroids and followed by rituximab, but this is a scan that was done post steroids 1 month, and you can see that the enhancement has completely disappeared. So this is a phenotype which then went on to have the name slippers. It's funny, but it is what it is. And so slippers is where the C gets replaced by S, and that's the supratentorial. And here the rest is the same except for the P here from pontine goes to parenchymal. And so there are very few cases, very few cases that have been reported. I think there are about 5 other cases that have been reported of slippers, and so it's a really rare presentation. Now coming, is the MRI really enough for us to say that, okay, this is clippers? And so I'd just like to go briefly over the histopathological features that are seen in clippers. And as you can see here, there is a very dense perivascular infiltrate again, and they are predominantly a CD4 T cell profile. The microglia can also be seen, and this infiltrates are seen predominantly around the blood vessel, but also more diffusely in the parenchyma around it. There is no evidence of vasculitis in the form of vessel wall splitting, fibrinoid necrosis, fibrin clots, but also in some patients, axonal injury can be seen, and it's also the correlate for the atrophy that you see on MRI in some patients. So answering the question, I would say yes, MRI and clinical details are enough in most of the patients, but where atypical features are present either clinically or radiologically, or when the patient doesn't show a response to steroid as expected, and the the investigations are not clear or equivocal, and so at that time a biopsy is definitely indicated. Going to the diagnostic criteria, which was proposed in 2017 by Tobin et al., which is from the same group in Mayo Clinic. And so it highlights the same 3 features that I've just gone over, which is the clinical, MRI, and neuropathological features. And an important part, of course, for clippers is that it should rule out any other alternate cause should always be excluded. So a definite clippers is a syndrome, is a diagnosis when the patient fulfills clinical and MRI and neuropathology. So all criteria in the absence of any other diagnosis. And a probable is the first two without evidence of neuropathology or without available neuropathology. And these are the two definite and probable clippers that you should know. And subsequently, the sensitivity and specificity was also evaluated. And though the criteria is pretty sensitive, it's not so specific. And I think we all know that because there are mimics of clippers that we see. And so that also drives the low specificity over here. There are multiple alternate etiologies and differential diagnoses that have to be excluded with clippers, and so the investigations are centered around these to exclude all these diagnoses, from autoimmune paraneoplastic encephalitis to primary angiitis of the CNS vasculitis, CNS lymphoma, other malignant disorders, and also demyelinating disorders like NMO, MOG, MS, but also neurosarcoidosis, Behçet. And so essentially clippers is a diagnosis of exclusion, and the evaluation should be carried out extensively. Coming to what we can see as mimics, and so here you can see that there are 13 patients, 13 cases where these patients were thought of as clippers, but you can clipper mimics, because you can see that there are, though they seem to have enhancement, seem to have enhancement in the pontine or peripontine regions or cerebellum. You can also appreciate that there are certain features that might be atypical, like larger lesions, or where they are asymmetric, or where certain other features can be seen, like in this case of the first case, the patient also had periventricular linear radial enhancement and was diagnosed as a case of GFAP eventually, and I'll be going into this later in my talk. This patient had a CNS lymphomatoid granulomatosis, and so also had enhancement which was like a ring-like heterogeneous thick enhancement with a necrotic core, and which was highly atypical of clippers. And this patient also had diffusion restricting lesions in the ACA territory, and subsequently was also seen to have a stenosis or a constriction in the A1 segment of the ACA. So going over this, though we said the clinical features don't distinguish patients from clippers or non-clippers, but the MRI features definitely can. And so if there are larger lesions or larger lesions that are more prominent on T2 than on GAD T1, the lesions which may have a necrotic core or a presence of mass effect, or larger lesions on enhancing nodules of more than 3, but also more importantly, more than 9 millimeter, a heterogeneous enhancement pattern, or most importantly, which also I think is here, is that the absence of enhancement following steroid treatment. This is an important point to be seen when patients present with atypical features. And these atypical features usually appear by the second event and a median of 5.5 months from onset. And so this is also the reason why the criteria has low specificity. So this is to drive in an important point over here. I would like to mention that the diagnosis of clippers at every relapse, it should be revised, reevaluated, and if there are any atypical features, it should be investigated in detail again. Coming to the treatment, it's without any treatment, clippers is a chronic disease. It has a relapsing course, and so treatment is extremely important over here. Mainly the acute therapy involves intravenous steroids, high dose IVMP 1 gram for 5 days, but in some cases may have to be given up to even 10 days. The dose can be evaluated as per the body weight of the patient subsequently. From the first attack to the last relapse in clippers, steroid sensitivity is the rule. So the patients are really sensitive to steroid, and the relapses tend to occur when the dose of oral steroids goes below 20 milligram per day. So it's advised that the taper of oral steroids after the IV dose is really slow, though there's no consensus as to how slow this should be. It is generally advised that 1 milligram per kg per day be given for at least 4 to 8 weeks, and then subsequently 10 mg per day reduced to 20 mg, and then much slower thereafter. As these patients tend to relapse on steroid taper, and also because of long-term steroid having its limiting use because of side effects, long-term immunotherapy also finds its place in the treatment of clippers, and with or without low-dose corticosteroids, but generally they are required. work patients. And methotrexate has been found as to be probably the most effective even without steroids. And so it is advised at a dose of 10 to 15 milligram per week, but in certain cases can go even higher. And the other medications that have been tried and have proven to have some benefit, but there are no trials for the treatments in clippers. And so cyclophosphamide, hydroxychloroquine, azathioprine, MMF can be tried. It's important to reevaluate the patient and also keep the patient on follow-up. So clinical and brain clinical examination, brain MRI have to be done every 3 months at least in the initial years. The last part in clippers is just like to also mention a point which has come up in recent years is the association with malignancy, which can be seen in about 15% of patients, and most of these are lymphomas. The patients that present with malignancies tend to be more of them are male, tend to have elevated CSF protein, and also have higher mortality. And so this raises the possibility that clippers may be a pre-malignant state, but also probably a pre-disease state for other mimics like we saw with CNS angiitis or even GFAP or MOG, but these are extremely rare cases. So this should also be thought of when we are evaluating a patient with clippers. Okay, so now I'm going to the next case, and I would like to thank Dr. Shruti Nair from Sri Chitra Institute for kindly providing me with the case details. This is a patient who's a 20-year-old male who presented with fever and headache for 2 days duration, followed by bladder symptoms and constipation, and then tremulousness and weakness of limbs. The patient on MRI brain had meningeal enhancement that can be seen in the anterotemporal region, but also unfortunately the brain scan images were not very clear because it was a scan that was done after 4 months, and so I don't have those images. But the patient at onset had a longitudinally extensive transverse myelitis from C3 to D12 segment with patchy enhancement, and also leptomeningeal enhancement in the anterior cervical region. So the CSF of this patient had 302 cells, 96% lymphocytes, and the other 4% were neutrophils. The protein was elevated at 113 milligram, and there was evidence of a mild hypoglycemia as well. This patient has CSF GFAP antibody moderately positive by indirect immunofluorescence assay in a titer of 1:10, was treated with steroids and with a mycophenolate mofetil subsequently, and has had a near complete improvement, and the repeat MRIs at 6 and 12 months have been normal. Which brings me to the second part of my talk, which is glial fibrillary acidic protein astrocytopathy, or GFAP astrocytopathy, and which was described first in 2016 again by the Mayo Clinic group and was called a novel meningoencephalomyelitis. And this resembled cases that were previously labeled as NAIM, which are non-vasculitic autoimmune inflammatory meningoencephalitis, which were described in the 90s. So probably those cases were also GFAP, but not a lot of them have had the samples to test. So what is GFAP? Now, it is a intermediate filament protein, which is a main intermediate filament protein in mature astrocytes, and it's cytosolic, it's intracellular, and its main role is usually in maintaining homeostasis, synaptic plasticity, regeneration, the reuptake of neurotransmitters, but also has a role, as we know, post any injury to the CNS, that it has a role in reactive gliosis. The GFAP astrocytopathy again is a disorder of middle age, and so it's in the 4th to 5th decade, probably around 45 years. It's still not clear whether this disorder has any gender predominance, but some reports have mentioned a slight female predominance, but also that it's not clear yet. The classical syndrome associated with this disorder is a meningoencephalomyelitis with a hallmark radiological finding that I will describe, and can have coexisting autoimmunity and tumors, and also is responsive to steroids. How is GFAP detected? So GFAP is usually detected, and it's the GFAP alpha isoform that we usually make use of because it's the most widespread and most prevalent. And it is tested in CSF, that is the what is advised, because the sensitivity in CSF is higher than that in serum. Also, it was initially found that that other disorders may have serum GFAP positivity, but most of these samples were from the serum. And so subsequently, it has been noted that in CSF, GFAP astrocytopathy has quite a high specificity, and very few control patients were found to have CSF minimum rare, like only I think one in patient was found to have CSF positivity in the CSF, which was a control, sorry, and from the Mayo group, and they test a lot of patients. Their testing rate and positivity for GFAP is almost 0.1 to 0.25% of their samples. They also advise that the screening should be done by a tissue-based indirect immunofluorescence assay, but it should be subsequently confirmed by a GFAP alpha transfected cell-based assay. So, which are basically they are the human embryonic kidney 293 cell line, which are transfected by the plasmid, which expresses the GFAP alpha. And to this is subsequently added the patient's either serum or CSF sample, and then tagged by a secondary anti-human IgG to then have which is tagged by the GFP, which is the green fluorescent protein, and where you can see that here in this case, in the first one, this is the GFP tagged GFAP alpha on a cell-based assay, and this is a control, so you don't see anything over here. And this is subsequently in the serum and then the CSF, and you can very beautifully see this red positive red color, which is indicates the positivity for GFAP in cell-based assays. Also, which was I would just like to mention, is that when you see what these images indicate are when we have the tissue-based assays, which is also the mouse tissue sections that are taken, and then you add the patient serum or CSF, and then similarly tag it with the secondary antibody. So you have this green fluorescence that is very beautifully seen, and here I can just show you that you can see it in the pile subpile region, in the periventricular region, the concentration, and which corresponds to in the MRI what we very beautifully see as a linear radial enhancement perivascularly. Here you can see that this is the spinal cord section, and this is the central canal, and again you can see that it is surrounded by a higher concentration of GFAP around the central canal. These are from cell-based assays. So here you have to see that in the cerebellum, again, very classically, you can see the radial enhancing pattern. And this is seen because of the Bergman glial cells that are present in the molecular layer. And this linear radial distribution is very characteristic of GFAP. So, yes, and the pathogenesis is still not extremely clear, but it has been proposed that that GFAP autoimmunity is triggered by either a previous infection or association of a tumor, which either has, because of molecular mimicry, the same antigen, or an previous infection then that exposes these antigens of the CNS to the periphery, and you have a subsequent autoimmunity. So also on the histopathology, you see similar features with extensive perivascular inflammation as we see in clippers. But importantly here to note is that this is a CD8 predominant disorder and not a CD4, which we saw in the case of clippers. Here also we can see CD20 positive B cells and plasma cells, and also there is no myelin loss that is seen in these patients. Okay.
Really sorry, already 22 minutes.
Sorry, I'm sorry. Okay, so I'll try to go through this fast. And so on the MRI, you classically see cortical, subcortical white matter lesions, but also these characteristic bilateral thalamic or external internal capsule and posterior pons lesion may be seen. Transient splenial lesions may be seen. The most predominant disorder is a meningoencephalomyelitis. And but you can also see blurred vision, optic neuritis, movement disorders, and others. These are the other enhancement patterns that can be seen other than the linear radial perivascular. So in the spinal cord, again, it's mostly the longitudinally extensive myelitis in the involving the central cord, and also many cases you see this linear central canal enhancement. Compared to aquaporin, they are less prominent lesions and with lesser edema. You also see this papilledema in many cases of GFAP astrocytopathy, and it can be a clinical clue while evaluating cases. just a small note that in certain subset of patients can also have normal MRIs. The other features that are present are the pleural infections, malignancies, coexisting autoantibodies, and hyponatremia. And the most common tumor to be associated is ovarian teratoma, especially in patients who have NMDA and GFAP co-positivity. So the differential diagnoses are as follows. And lastly, coming to the treatment, mostly these patients are, again, also they respond well to steroids and are steroid sensitive, and so tend to relapse when steroids are tapered. Relapses are seen in about 20 to 30% of these cases, and more frequently in those with overlapping antibodies with the Acoporin, MOG, and so on. The acute treatment is with either IVMP, Plex, or IVIG, and they have a good response. The long-term immunotherapy is not yet well established. A lot of patients are on chronic corticosteroid therapy, but also on these other medications that we use routinely. Okay, so patients with myelitis, visual involvement, or overlapping antibodies may require long-term immunotherapy compared to others. And so just a recap of the last, I'm sorry I'm going over time, but this is the last part of, because of the first case that I presented, which was a patient over 7 years, had 7 relapses with excellent response to steroid every time. And in subsequent MRIs, as you can see very clearly here, that also goes on to develop perivascular linear radial enhancement, and was subsequently, after 7 years, diagnosed as a GFAP positive case, and the diagnosis changed from Clippers to GFAP. This is a rare presentation, but should be considered. And okay, I'll skip through this. And so lastly, these are steroid responsive and sensitive disorders, and where atypical clinical or radiological features are there, it should be extensively evaluated with all possible investigations that are available. Sometimes a biopsy may be necessary and it should be obtained. Recheck and reevaluate when steroid response is inadequate, and overlapping syndromes and malignancy workup should be considered. And surveillance for tumors should be done for at least up to 2 years. So that's my last slide. And thank you for your attention. And I'm sorry again for going over the time.
Thank you, Kshitija. Thanks for bringing out the MRI clinical features and the pathophysiology, especially in both these disorders. I really thank all the speakers who did a wonderful job, especially bringing about the newer criteria which has come in MS from Dr. Suresh, Dr. Fujihara, who brought about very well about the importance of the different phenotypes which are there, and how the cell-based assay has to be tested, what are the different IgG, IgA, and the type of treatment which has to be given. I think that was brought about well. And finally, Dr. Kshitija, who brought about the Clippers and GFAP as to how to distinguish what are the characteristic features and clinical features in both clinical and MRI. I request attendees to post their queries on the chat box. I'll go through a few of them. Dr. Fujihara, we'll start with you. One of the person has asked about the treatment as to how to differentiate false positive MOG antibodies.
Well, thank you very much for the questions. It's a great question. And actually, at this point, if the patients do not have, features of MOGAD, and if the antibody titers are low, so if it's low positive, then we judge that those patients are probably false positive. So it's not based on the features of the antibody binding patterns. So some investigators still believe that, for example, some MS patients may be low positive, and they believe that low positive MOG may play a role to modify the features of MS. But among the members of the international panel, those MS patients with low positive MOG are probably false positive. But still, we do not know the details of the features of antibody binding. So that should be clarified in the near future.
What about the repeat testing? Does it happen that if they are false positive and if we retest it after a few months, And
Yes.
will it remain positive? How does that happen? If you can shed light on that, Dr. Fujihara.
Well, for example, if the initial test was negative, well, you may repeat the testing probably at the time of relapse. So then the patient may be judged as positive. But on the other hand, even if the patients were initially positive, if you see a patient in a chronic stage, maybe more than a few months after the onset, then you may check the blood, and at that point, the patient may be negative. But it's still possible that the patient at the onset was positive. So if the patients really have the typical features of MOGAD, you had better test the blood or CSF at the time of acute exacerbation. So over time, maybe 30 or 40% of the patients revert to negative. But on the other hand, are there any patients who convert from negative to positive? It's relatively rare. And as far as I see the questions, some patients may experience relapse after they reverted to seronegative. Is it still called a relapse of MOGAD? It's a good question, but we don't understand everything, but it rarely happens. So that's the difficulties of evaluating the meaning of MOG-IgG at this point.
Thank you, Dr. Fujihara. At the same time, I also want to know, are there any clinical predictors which tell that when we start treatment maintenance therapy for MOG patients, will we be able to tell that these patients have a bad risk and bad prognostic factor, so we need to continue the treatment? And if so, for how long?
Well, as I showed you in one of my presentation slides, generally speaking, the patients who had myelitis at the onset carried a relatively poor prognosis in comparison with other clinical phenotypes. So, well, at the onset, we don't know if the patients will experience a relapse in the later course of the disease just based on the clinical features. But if the patient's onset event is relatively severe, we may start long-term immunosuppressive treatment from the beginning. Otherwise, most experts think that initial immunosuppressive treatment may be continued for a few months to, well, several months, and then they try to taper or discontinue the treatment to see if there's any relapse. But we still do not understand why some patients experience a relapse and which factors really trigger the relapse. That's a big question.
And how do you go about, do we do the repeat antibody testing? And does it determine as to whether you continue the treatment or not?
Well, so generally speaking, if the patients who were initially seropositive revert to seronegative, compared to the patients with persistently seropositive, they are less likely to experience relapse. So if the patients MOG-IgG revert from positive to negative, well, you may discuss with your patients discontinuing the treatment. But as I said, there are exceptions, so you should be careful.
Thank you, Dr. Fujihara.
You're welcome.
Yes. Over to you, Dr. Suresh. Main thing is about the criteria. what is the modification which has happened? I know you brought it about, but if you can just bring about the gist about the newer modification which has happened in 2024 in the MS criteria.
Now, why do we have criteria for diseases? We have criteria for syndromic diseases. We have multiple symptoms and signs, and you don't have a clear lab or radiological biomarker to tell that this is the particular disease. When you actually develop on diagnostic criteria, you're trying to increase the sensitivity and specificity of diagnosis of that particular disease or syndrome. So that's what we are trying to do. See the 2000, the McDonald's criteria from 2001 onwards has been trying to do that to increase the sensitivity and specificity of the diagnosis of multiple sclerosis in 2001, 2010, and then 2017. So we are going one step ahead in 2024 and trying to see what we can actually do better on what is already there. So the first thing is the optic nerve involvement. The optic nerve involvement now, it has a fifth topographical site for dissemination in space. That means other than the periventricular nerves, brainstem areas. Now we have also we can second is like the addition of the CSF kappa free light chain would be equivalent to CS oligoclonal band, which is it's very similar to OCB, the kappa levels. In almost all the stages of the disease, it can increase during a relapse. So it's been quite sensitive in a specific sensitive in the diagnosis that has been added. Then this two radiological markers again. One is the central vein sign. If we can show a dot central vein, demyelinating white matter lesion, then that adds on to diagnostic criteria. Then the paramagnetic rim lesions, which are seen, the lesions with paramagnetic iron deposits are seen as a dark rim around the lesion, which is called a param. So if you see these, then that adds on to it. So now what has majorly changed in this 2024 diagnosis is the big question whether and we should treat radiologically isolated syndrome. So far, we were not doing it because this is a patient who has only, findings suggestive of multiple sclerosis on MRI, but doesn't have any clinical sign or symptom. These are RIS. Now, should we treat them? So now, the radiologically isolated syndrome, the captain is saying that if you have dissemination with space, is already there on the MRI. Then you can even prove dissemination in time in the same MRI. Or you have one of the CS biomarkers which are positive, either the kappa light chain or the CSF. Or if you have 6 central vein signs in the same MRI, then you can make the diagnosis of multiple sclerosis confidently, and probably they will be treated in future, these patients, without any clinical symptom or sign. So the diagnosis will be made based on this. That is one of the biggest change which is going to come in the 2024 criteria. So MRI to treat patients with RIS.
Thank you.
That's in a nutshell about what
Yeah, thank you, Dr. Suresh. I think main thing is about the optic nerve coming into the criteria.
Yes.
And we previously thought of only OCB, but now we have more sensitive kappa-free light chains and 2 radiological signs, especially the central vein sign and the paramagnetic ring, which rules out the other differentials. I think these 4 has the main thing, which has increased the specificity of the MS criteria. Thank you, Dr. Suresh. And what would you say about, I think many people have the question on rituximab in multiple sclerosis. I know you did not touch upon the therapy, but because many people have asked and that is being quite commonly being practiced in India, I thought I'll bring it about.
So I think I will take on that question because I did, due to shorter time, I just gave an outline of treatment of MS with all the drugs. Didn't go specifically into each drug due to shorter time. Rituximab definitely is a drug which has shown a lot of promise in Indian setup, where cost is a big factor. And in general, B cell depleters, monoclonal antibodies have been very successful throughout the world. If you take ocrelizumab, ofatumumab, and now ublituximab coming up. So we don't have these drugs, and we have some of them, but they are very costly. So what we are doing is using rituximab. So now rituximab is being used in various scenarios. I've seen rituximab being used in government setups as a first-line therapy, for early multiple sclerosis. I have seen it being used as an escalation therapy where the first drug fails and then you take it up as a second-line drug for for an aggressive kind of multiple. I've seen it being used in active SPMS, that is secondary progressive cases in. We have seen other uses of rituximab, like low dose rituximab have been published from India. The dose lower doses than the 1 gram dose which we usually give, and we have also have tried extended intervals between doses, like up to 9 months, sometimes to a year between 2 rituximab doses. So all this has been tried in the Indian scenario and setup, and most of them, the patient seems to be working on patients. So yes, rituximab is a very major drug in this part of the world to control multiple sclerosis, and should be increasingly used with confidence by most clinicians when and where you require it, keeping the patient in front of you and the stage of the multiple sclerosis. And so personally, if you ask me, I don't start rituximab for patients with clinically isolated syndrome or very early multiple sclerosis with very few lesions. I don't start them, but I do start rituximab as a drug when the first line platform therapies fail, and then it's my next go-to drug.
Thank you, Dr. Suresh. I think because of the time, we'll just go with one last question to Dr. Kshitija. Dr. Kshitija, would you classify the clippers and GFAP under the spectrum of vasculitis? I know you brought about, but because there were a few questions,
Yeah,
just...
I'll try to say that. So, generally, both of these disorders are considered perivascular disorders because they don't actually the cells don't there's no vessel wall infiltration and splitting of the vessel wall and subsequent features of vasculitis that you see. Like fibrinoid necrosis or fibrin clot formation. So the pathology shows that they are densely perivascular around it, but very few cases of clippers have shown that it may be transmural, but it never really causes vessel wall splitting and other features of vasculitis that we see. So it's not a vasculitis. Also, radiologically, you don't see infarcts, microhemorrhages, etc. on MRI. So it's also something that can be used as a differentiating factor. And you also see leptomeningeal enhancement with vasculitis. Can be seen with GFAP, but not usually with clippers.
Yeah. Thank you, Kshitija. I think in the want of time, we would like to close the session. Few of them
May I
have already...
one thing about these disorders that I wanted to say was also that the CSF in GFAP may be a little bit useful to differentiate it because also though it is cellular, it has high protein elevations, there are a proportion of patients that have low glucose. So hypoglycemia in the CSF and also have oligoclonal bands. So maybe sometimes compared to clippers, these features are more pronounced in GFAP.
Thank you, Kshitija.
Thank you.
I thank all the speakers for really giving a very nice talk, and it's been a wonderful to learn about the spectrum of all the CNS demyelinating disorders. Thank the attendees for attending and putting up their uh, questions. I am sorry that we couldn't answer everything because of the want of time. And thank the digital team and Asmita for hosting this. Thank you, Ivan.
Thank you very much.
Thank you, everyone.
Thank you very much.
Thank you. Thank you.